let's start talking about ENT. And I would tell you that I saved this one for the end of the day because I think that most people have the most experience with ENT. And I also think that your brain is pretty much toast right now. And so I got to hit you with something that is familiar to your brain. And also, I got to give you something that's brief. So this will be our shortest one of the day. So here's what we need to talk about. I need to make sure that you know about sinusitis and the new guidelines that you ought to be using in practice. I need to make sure that you know about pharyngitis. In the realm of ENT, I'm pretty sure that you would guess that an emergency question would be on epiglottitis because it can produce acute airway closure. Mono, there's always a question on the exam about mono. And honestly, if you see people with acute illness, you're going to see adolescents who come in with mono. I want to make sure you nail it. Then we'll move to the nose and talk about epistaxis and allergic rhinitis. There is one hearing loss question that I'm pretty sure you'll run into regardless of which exam you take. I need to make sure you know about presbycusis. And then finally, we'll look at a couple of eye things and we'll call it a day. So hang with me. I promise you're going to make it. Sinusitis does not always mean infection of the sinus cavities. When a word ends in itis, what do you think of? Inflammation, and that's exactly what you think of with sinusitis. The inflammation can be produced by a bacteria, a virus, or an allergic sinusitis. So don't forget to include that one in your differential. Just as a quick anatomy, look at this picture. When people have sinusitis, the two most common sinus cavities that are infected are the frontal sinuses, which are up here, and the maxillary sinuses. But you have two more sets, and here they are. You have the ethmoid sinuses and the sphenoid sinuses that can produce pain in this area. You see it? These are small and narrow tracts, and when those sets of sinuses become infected, they are very difficult to drain. So those are much harder sinus infections to clear. Now, you'll see this acronym in practice, either ARS, acute rhinosinusitis. Sometimes you'll see ABRS, acute bacterial rhinosinusitis, or AVRS, acute viral rhinosinusitis. Regardless of the etiology, patients typically present with the same set of symptoms, and I'm pretty sure that everybody in this room has had it at least once. You came in with nasal congestion, but what ought to make you think an etiology that's a bug, like viral or bacterial, is purulent nasal discharge. The other thing that ought to make you think of a bacteria or virus, especially bacterial, is facial pain, which is a question you ask a patient who presents with sinusitis. When you look at the two things that are most predictive of acute rhinosinusitis, it happens to be the finding of purulent nasal discharge, which is why you ask that question, and the other is facial pain or tooth pain. And if you remember my picture of the sinuses, you'll realize why people complain of pain or tooth pain in the upper sets of teeth. Well, I don't know what's on your bucket list, but if what was on your bucket list is to win the Nobel Prize, I'll tell you right now how to do it. You would be granted a Nobel Prize if you were to be able to distinguish and differentiate bacterial sinusitis from viral. And you know why they give you a Nobel Prize? Because you had made such a tremendous impact on antibiotic resistance that you would be hailed as a Nobel laureate. The trouble is we don't have a good way to differentiate viral from bacterial sinusitis. Consequently, we look at some of these clues. These clues ought to make you think that a patient with rhinosinusitis has a bacterial etiology. I want you to take a look. For people who have symptoms, rhinosinusitis symptoms that last longer than 10 days is probably not viral. If it was, it would have run its course had it been a viral infection. So more than 10 days, think bacterial. A second symptom that ought to make you think bacterial is this one. People who had severe symptoms when it started, severe means fever. People with sinusitis don't run fever. People with other things, upper respiratory infections, might run fever. If you have a sinusitis and you have fever, you have a very bad infection. You need to presume that it is bacterial and treat them accordingly. The third clue that ought to make you think bacterial is people who got symptoms. They started with symptoms, they got better, and then all of a sudden, oh man, I got bad again. That should make you think of a secondary bacterial infection. Here's the deal. Half or more of patients who have a bacterial sinus infection clear spontaneously without an antibiotic. How do we get them to do that? We get them to do that by trying to promote drainage. So listen, I gave you those acronyms before, ABRS and AVRS, and that is exactly the acronyms that are used in the brand new sinusitis guidelines. Brand new is kind of in quotes. Brand new means 2012. So you should see this being used in your clinical practice, and to be honest with you, it is certainly fair game on your exam. So when a patient presents with a rhinosinusitis, your goal, regardless of the etiology, is always to promote drainage. That's always what you want to get it to do. Even if it's bacterial, if you can get that purulent mucus to move and get out and empty the sinus cavities, you don't always have to have an antibiotic. So, Amelie, what was new about the new sinus guidelines? Well, here's the first thing. The first thing is that amoxicillin is no longer used first line, according to the infectious disease people. The reason amoxicillin is not a good first choice is the reason you would guess. There is way too much resistance with strep pneumo, and there's a higher rate of H. flu, which amoxicillin really does not address. The new antibiotic that we use first line for our treatment of acute sinusitis is Augmentin, amoxicillin with clavulanic acid, because of its excellent beta-lactamase coverage and because of its ability to knock out H. flu, Haemophilus influenza. Who harbors H. flu when they get sick? Smokers, right? H. flu, the pathogenic kind, inhabits the upper and lower respiratory tract of smokers, and so certainly you have to consider that. What would you give, according to the new guidelines, if your patient was pen allergic, meaning you could not give Augmentin? The guidelines say, we got you covered. Give doxycycline. It's a good alternative to first-line treatments. And if you can't give that one, or if you've had a failure with Augmentin or doxycycline, the guidelines say, jump straight to a respiratory fluoroquinolone. So take a look at something. The new guidelines specifically said, do not use macrolides, like azithromycin, like a Z-Pak. The reason the new guidelines say don't even waste your time is because of the high rates of resistance. We've known for a long time not to give trimethoprim sulfamethoxazole. It doesn't cover the most likely bugs, but the new guidelines recommend that you don't use a second or third generation cephalosporin either, because they don't have good enough coverage against A, beta-lactamase producers, and B, those resistant organisms that we see with strep. So what about peds? Do the same rules apply? Well, kind of. With peds, the Pediatric Infectious Disease people released a guideline in 2013. It is fair game on your exam. First line for kids can be amoxicillin with or without clavulanic acid. In kids, we still are okay with using these second and third generation cephalosporins, but even in children, the recommendation is the same as adults. No sulfa drugs and certainly no macrolides, all right? So be smart. So one big change with the guidelines is what drug you give. The second big change with the guidelines is how long we give the antibiotic. I would like to know how many prescriptions for Augmentin 10 days I have written in my lifetime. Probably hundreds, probably thousands of them. Maybe not thousands, but just loads and loads of them. The new recommendation is to treat for 5 to 7 days, because 3 days likely kills the bug if you got them on the right antibiotic, and another 2 to 3 days. So what's so great about 5 to 7 days instead of 10 to 14? We get fewer side effects and complications, we get better compliance, and we get equal efficacy. So man, it is a win-win. So the two big changes, the antibiotic we give, first line is Augmentin. Second big change, how long we give it, no longer 10 days. Well, I wish you had a better look at this lady's eye, but this is your patient who just walked in. She's got nasal congestion, purulent nasal discharge, and a headache. I want to know what you think this is all about. Is anybody thinking that she's got periorbital cellulitis. Do you remember the word we used yesterday afternoon about this time? It was a word I used to describe the movement of bacteria from one place to another. What was that word? Translocation. I want you to think about translocation because she probably started with a sinusitis. The bugs translocated from the sinus cavity to the skin under the skin around her eye. So I believe that if with your diagnosis, I think you have to consider periorbital cellulitis. All right, now, with an acute rhinosinusitis, which she obviously has, probably a periorbital cellulitis as well, there are good reasons for referral. One of them is an elevation in body temperature. People with sinusitis don't run fever of 102. They got something else going on. A change in vision, and certainly as this lady has, periorbital edema, which may indicate periorbital cellulitis. You've got to be ready to move on that. And that's a certain cause of referral for a patient who's got this. Unless you watch them every day and you can give them Rocephin or something like that every day. All right, so you're good on that one. Let's keep going. Take a look at pharyngitis and tonsillitis. Everybody in this room has had it before. It's miserable when you have it. And when your patients come in, they're miserable too. When a patient has a bad sore throat, what do they always say? I have strep throat. Well, the truth is most adults do not have strep throat. In fact, 5 to 15% of adults with pharyngitis have group A beta hemolytic strep. The rest of them have something likely that is viral. So here's your patient. Your patient presents with abrupt onset of sore throat, tonsillar exudate, tender cervical adenopathy, fever that began 24 hours ago. I'm sure you've seen a ton that look like that. My first question for you is this one. What statement is true if this is group A beta hemolytic strep, GAS? If this is really strep, it's not going to worsen over the next 5 days. In fact, it's going to get better. Number 2 is your best answer. If this really is strep, it will spontaneously resolve within the next 2 to 5 days. You know what? Strep doesn't have to be treated with an antibiotic because of number 2. It will spontaneously resolve within the next 2 to 5 days. So with the patient we just talked about, we sometimes use something called the center score, or the center criteria, to help us evaluate whether an adult with pharyngitis has strep or not. So look at the 4 indicators of strep. The first one is an absence of cough. If your patient, adult patient with a sore throat comes in and they do not have cough, they get a 1. If they have positive anterior cervical nodes characteristic of strep, they get a 1. If they have an elevation in body temperature, 100.4, they get a 1. And if you examine the throat and you see tonsillar exudates or swelling, they get a 1. Now you look at the age of your patient. If your patient is the age of anybody in this room, we're either going to give them a 0 or we're going to subtract 1 from their total score. This is how you evaluate pharyngitis in an adult. So you get your score, and here's what we know. If the score is 2 or higher, it justifies your using a rapid strep to see if that's strep. If the score is a 1 or 0, the guidelines say it's not strep. Don't waste a rapid strep on it. That's an expensive way to get to an obvious conclusion. So again, most adults do not have strep throat. But I want you to put an asterisk by that statement because this is what you need to consider. There are some adults who are at increased risk of strep, and here's who I think of. People who are immunocompromised, like somebody with rheumatoid arthritis, somebody who's on prednisone every day, somebody who might be around little kids who have strep, like a first grade teacher, a daycare teacher. What about a grandmother who has custody of their kindergartner, the daughter's kindergartner, the son's kindergartner? What I would tell you is look for adults who have high exposure to strep because they might be the people who will be positive for group A strep, and they are an unlikely candidate on first glance. Everybody with me? Let's keep going. How do you diagnose sore throat? Like strep throat. You could get a rapid strep, and rapid streps usually mean, if it's positive, it usually means they really do have strep. But just because a rapid strep is negative doesn't mean the patient doesn't have strep throat. So listen, here's what I want you to consider. A rapid strep is about $20 to $60 depending on where you do it. A culture is going to cost you well over $100. You've got to be savvy about use of resources. Wherever you land, I don't know what clinic you're going to land in, but if you do rapid streps in that clinic, you need to open the box, the kit where the rapid strep tests are, and I want you to open up that little piece of paper. The piece of paper in that rapid strep kit is going to tell you what the sensitivity of the kit is. In other words, the ability of a test to identify strep when a patient really has it. If the rapid strep kit that you are using is a cheap one, it may only identify strep 50 to 70% of the time. If that's the kit that the office manager is ordering in your clinic, then you're going to have to follow up a negative rapid strep with a culture. If, on the other hand, you are using an expensive rapid strep kit and the sensitivity of the kit, meaning the ability to identify strep when it really is present, is 90%, then if it's negative, you can pretty well rest assured and say it's not negative, it's not strep. So don't let an office manager make you a liability. Make sure you know what the sensitivity is of the rapid strep kit in your office. Because if you're using a cheap one and the sensitivity is low, you're going to miss strep when it really does occur. Amelie, I don't see what the big deal is. I mean, didn't you say on the previous question, in 2 to 5 days it goes away without problems, without treatment? It sure does. Why do we treat strep? It's not to make it go away. The reason we treat strep is to prevent the sequela of strep. Like what? Acute glomerulonephritis. You got it? Damage to the heart valves. That's why it is so important to identify strep and treat it when a patient has it. Quick question. A bad kit, a cheap kit. I'll be honest with you, if you got a cheap kit, I'd rather spend the same amount of money on a more expensive kit and not have to send a culture out. Do you know what happens? Rapid strep on a cheap kit is negative. You're thinking, you know what, it might be strep. Let me get a culture. You get a culture. It sits on the counter in your office. If that thing sits for more than 2 hours, the bugs are dead. Bugs don't grow at room temperature. They grow at body temperature. If the room temperature in your kit, in your clinic is 72 degrees, your temperature is 90-something, 98, 99, 100 if you have strep. Those bugs will die in no time. So I'd rather spend my money on a more expensive strep kit and not have to worry about getting a culture sent out that's an hour on my counter, then it's in the core of the lab courier and it makes it to the lab 4 hours later. I hate sending cultures like that because you never know if those bugs are still alive when they get where they're going. And I guess I'm kind of a bug fiend, but I'm just telling you, you got to protect those little bugs. If they die, you've lost good information that will help you make a clinical decision. So let me get back on track, but thank you for that question. In adults, the bottom line is most pharyngitis is viral, and these are your most common pathogens. So what about pharyngitis in adults? Most are viral. Sometimes it's secondary to an allergy, and it produces a what? A postnasal drip that causes sore throat. But again, a number of things can produce sore throat in adults. I mentioned strep, and the reason we treat strep throat is to prevent those sequela. The word sequela means something that comes after. And the reason we treat strep is to prevent something like acute rheumatic fever, acute glomerulonephritis. Scarlatina is an example of a sequela of strep that produces a sandpaper textured rash. Not terrible, but to be honest with you, you'd rather not have scarlet fever after an episode of strep. So have a heads up about it. It is a very bad bug. Look at this. An adult patient presents with suspected epiglottitis. Bad, right? How should this be managed? You want me to tell you something right now? You better get them out of your clinic PDQ pretty damn quick. How come? You got to get them out of your clinic because if they've got epiglottitis, they always risk abrupt airway closure. And you know what I tell the students I precept? Listen, when a Canadian ambulance drives up to your clinic and hauls off one of your patients, it's bad for business. Very bad for business, right? So you want to get these patients out, PDQ. What's your job? You better get them to a place where they can be trached if they have an abrupt airway closure, because that's your worst fear with epiglottitis. Look at your epiglottis. You see it right here? If that swells and includes the airway, you need a trach. Most people don't do that in their primary care setting. So how does it pay? Right, you don't do that in your office, right? That's what I thought. All right, so listen, that and cataract surgery, we just are not doing it in our clinic yet. So listen, how does a patient with epiglottitis present? Let me tell you how they present. It's an adult who comes in with a terrible sore throat carrying a box of Kleenex. Are they blowing their nose? No. What are they doing with that Kleenex? They're using it to spit out their saliva because their throat is typically so bad that they can't swallow their own saliva. And so I would remind you that if you see something called a thumb sign, they're talking about epiglottitis. All right? What it represents is an enlarged epiglottis that protrudes from the anterior wall of the hypopharynx and just is called the thumb sign. And if you see that, it is always a patient with epiglottitis. Get them out. What about mono? Mono is darn common, and I think you'll see one of these on the exam. Most people with mono, in fact, almost every one of them, has a viral infection caused by EBV, the Epstein-Barr virus. And people with mono have these two symptoms that are so characteristic of it: malaise and fatigue. And those poor adolescents who come into your clinic with mono are either lying down on the exam table because they're too tired to sit up, or if they're sitting up on the exam table, they're usually leaning against the wall. They're exhausted. When you look at them, you can almost say, you look just like you have mono. I want you to notice the age of the next patient you'll take care of. Here's your first one. It's a 19-year-old who has been diagnosed with mono. Which symptoms are most commonly associated with mono? Well, Amelie calls mono the 3 F's and an L, because people with mono have fever, pharyngitis, fatigue, and lymphadenopathy. So I want you to circle number 1, number 2, and number 3. People with mono do not have abdominal pain. Look at the age of this adolescent. A 15-year-old presents with suspected mono. Which choice describes lymph nodes most commonly identified in a patient who has mono? Okay, wait, hold on. The lymph nodes in a patient with strep are where? Typically anterior cervical. The nodes that we typically see in a patient with mono, would you say that they're posterior? You should. And typically they are symmetrical. You got it? So they'll be both chains in the posterior cervical area. Not a single node, not one chain, but typically symmetrical and posterior. That's the most common thing we see with mono. So circle number 3. Here's a tetrad, the 3 F's and an L: fatigue, fever, pharyngitis, and lymphadenopathy. Once again, posterior cervical nodes are most commonly involved. So how are you going to diagnose it? Well, you really can't look at a patient and say, you look just like you have mono. But what you need to do is a screening test that is called a monospot. The monospot detects the presence of heterophile antibodies. So if you have mono and you made antibodies, your test will be positive. If the monospot is administered too early in the clinical disease course, it won't pick up antibodies that were produced because they hadn't been produced yet. So if you get a negative monospot and 5 to 7 days later the patient is still looking like they have mono, repeat your monospot. It will be positive if that's what they've got now. So again, monospot used to detect the presence of heterophile antibodies. It is far less expensive than an Epstein-Barr virus titer, which can cost you $200 to $400 depending on who does the test. In addition to a positive monospot, if you are so inclined, you should know that if you get a CBC in this patient, you will see a predominance of lymphocytes. If you were so inclined and you were to get liver enzymes in this patient, you should note that they will be elevated in more than half of your patients, which should tell you as a caregiver that mono is a disease that is systemic. It's not just a sore throat problem. It's a systemic problem, and that should help hammer home the point about how important it is to make these adolescents curtail their activity until they feel better. There's one more thing you'll find with mono. Because Epstein-Barr creates a systemic infection, it will change the appearance of the patient's lymphocytes, such that when a med tech looks at those patients' lymphs, because they're in greater number than we would expect, when they look and examine the lymphocytes, they will have changed their appearance such that we use the term atypical lymphs. So that's not unusual in a finding when you get a CBC and a monospot in an adolescent who looks like that. So here's your patient. A 16-year-old who is diagnosed with mono asks how soon he might be able to resume sports. He plays soccer. What should you say? Well, you know what? A, you have to feel better and have had a return of your normal energy. But you know what? I got to make sure that if you were the 50% of people who had an enlarged spleen, that your spleen went back down to normal size. Typically 3 to 4 weeks after onset of symptoms, that has occurred. I think your best answer is number 4, so go ahead and circle that one. And so suppose he had an enlarged spleen and he resumed activities too soon. Theoretically, what could happen? A splenic rupture, right? Bad for business. All right, let's keep going. What about epistaxis? This is not a disease. What is it? It's a symptom, and you got to figure out why in the world is all this blood coming out of their nose, because you can be very impressed by the amount of blood that comes out of somebody's nose. Why does that happen? Well, here's a list of things. Certainly it is not exhaustive, but you want me to tell you something? You will never believe what people put in their noses. I'm not kidding you. Keys, screwdrivers, straws, ink pens, toothpicks, safety pins, and things I'm sure they've never even told me about. So you just will never believe what people put in their nose. The reason that's important for you to know is because of nose bleeds. Let me show you. 90% of bleeds occur right here where a toothpick, safety pin, or key could be put. This anterior nose or anterior bleed is the most common place for bleeds to occur. This spot is called Kiesel-Bach's plexus. It is very susceptible to injury, especially if the mucous membranes are already thinned because of something like allergic rhinitis. 10% of bleeds are posterior bleeds, and I am not kidding you when I tell you, you better get them out of your office. A posterior bleed can involve the carotid artery or the sphenopalatine artery, and these patients can bleed an incredible amount of blood very rapidly. Thankfully, that is not the most common place that bleeds can occur. So when a bleed comes into your office, you want to look and see and try to be assured, although you can't always tell, that it is coming from the anterior nose. Feel more comfortable about an anterior bleed than a posterior one. Now look, how are you going to manage this in your office? Or if somebody calls you from home? You could get them to spray their nose with oxymetazoline. What is that? Afrin. You could get them to spray with duration, neosynephrine. Those are topical vasoconstrictors, and if it's not a bad bleed, it'll either buy you some time or it'll stop it. You could keep that in your office as well. Every first grade teacher knows how to stop a nosebleed. What do? You pinch the nose. So you could spray with Afrin and get a pinch the nose for at least 10 minutes, but the patient with a bad nosebleed needs cauterization. If you work out in rural health, good luck. There is something you can do, but if you cauterize a nosebleed and you use this patient better be your last one of the day. A cauterization agent that you should keep in your clinic if you work out in rural health is a silver nitrate stick. Now listen, if you use a silver nitrate stick in somebody's nose, you'll cauterize the bleed if it's an anterior bleed. But they will scream bloody murder. And so look, here it is again, patients in the waiting room, from behind the door. Ow! When you hear screams like that, people look at each other and they're like, out of here. And they get out. So I would tell you, it better be your last patient of the day. It really works, but it is, as a patient told me, I thought you had a welding torch up my nose. That must burn a lot. So I was very impressed with that. There is one more thing you can do. You could keep a pediatric urinary catheter in your clinic. You can nose it or snake it up above the level of the bleed and blow up the balloon. Pull the balloon or pull the catheter down so that the blown up balloon is now applying pressure over the area where you see the bleed. You got it? Tape it in place. Now you got the visual of this? Yeah. Do you know what these patients look like when they walk in? They look like they've been shot in the chest because there's blood everywhere. So just imagine what a patient is thinking who's sitting in your waiting room, and this patient comes out the back door, out the door. They have this tube coming out of their nose and blood all over. That does not instill a lot of confidence in a nurse practitioner. So make them go out the back door. All right, that's the point of the story. But again, they need referral for cauterization. What about a quick question?
Yeah, if it's posterior and you can't see it, I mean, that's just an automatic referral, would that not be?
Always an automatic referral. If you can't identify whether this is anterior, posterior, it's posterior until proven otherwise. Get them out. They can bleed so quickly. I'll tell you what, a friend of mine's husband had one of those posterior bleeds in Sam's. He bled out 4 units and they found him in the aisle. Never had a nosebleed before. You can bleed an incredible amount. So I am afraid of posterior bleeds because I don't have the potential to get in there and cauterize them. You need somebody who knows what they're doing, and I'm not the person, all right? I suspect ENTs don't like those bleeds either. You know, I do. Let's move to the nose and talk about allergic rhinitis. When you have allergic rhinitis, I tell people all the time, you have an expensive disease. Look at how miserable this man looks. Do you know how much money you can spend treating allergic rhinitis and not be completely free of symptoms? Here's what the guidelines recommend. First line therapy is always a topical nasal steroid. It is not an oral antihistamine. The reason a topical nasal steroid is considered first-line treatment is because when you use day after day a topical nasal steroid, look, it downregulates the inflammatory response. What does that mean? That means over time, your response to those allergens diminishes. That's why it's considered first line. But the topical nasal steroids are expensive. So for people who have no cash and no money, the simplest and least expensive way to manage their symptoms is with one of those oral antihistamines. And in many patients, you'll use a topical nasal steroid plus an oral antihistamine. So consider that, but honestly, this is an expensive disease to treat, and sometimes you end up just having to get a patient referred into allergy and immunology to see what you can do to help with their symptoms. It really, really diminishes people's quality of life, all right? So look at some of the drugs that we use to treat allergic rhinitis in addition to a topical nasal steroid and an oral antihistamine. Honestly, you just like got slim pickings once you start reaching for decongestants or maybe a leukotriene blocker like a Singulair. To be honest with you, once you reach this point, you certainly need to consider referral. Let's talk about an ear problem like this one. A 16-year-old complains of muffled hearing in his left ear, ear pain when opening his mouth wide, and tenderness when his left external canal is manipulated. What does he obviously have? He's got otitis externa, also called swimmer's ear. Exactly. Listen, when a patient has swimmer's ear, what is the most common pathogen? Pseudomonas aeruginosa, exactly. So Pseudomonas, and I'll leave it at that one. Look at this. What about hearing loss? It's extraordinarily common. It's got a number of different etiologies. And if you want to make 100 on this exam, I would tell you that you should learn all about these tuning forks. But in reality, if you want to know if somebody can hear, you don't pick up a tuning fork, bang it on the table and say, tell me when you don't hear it anymore. Really, what do you do with a patient if you want to assess whether or not they can hear? You send them to an audiologist for like a real exam. So that's what I would encourage you to do. So look, you can play around with the tuning forks. And one more time, if you want to make 100 on the exam, go learn about the tuning forks. I made a chart for you. Learn the chart and you probably make 100. But to be honest with you, this might not be low-hanging grapes at this point, right? So listen, the Weber and Rhine tests are the two that we talk about. And I think the best way to learn this, to be honest, is to get a tuning fork. Know whether or not you have normal hearing. Bang it on the table and figure out when do you hear. Is it lateralized to one side or the other? That's how you learn. That's how I learned it. And that probably will be how you do it. But to be honest, I haven't used that in practice with a patient that I have a concern about their hearing. I send them to somebody who can give a real exam. And it isn't me with the tuning fork. All right. So there are two forms of hearing loss that you need to know about. One of them is a conductive hearing loss. A conductive hearing loss means sound can't get into the external canal or the middle ear. And if that is your problem, then you'll have a conductive hearing loss. If sound can't get into the inner ear or the eighth cranial nerve, then you have a sensory neural hearing loss. And so, what are some examples of a conductive hearing loss? I'll tell you, I see this all the time. I work for a medium-sized hospital with healthcare providers who put stethoscopes in and out of their ears all day long. Invariably, they come in with cerumen impaction. They can't hear. Because it happens gradually, they don't notice that they have lost their hearing. The minute I pull out a plug or flush out a big plug of cerumen, they usually look at me and they all say the same thing. What is it? I can hear. So a conductive hearing loss is typically reversible when it's a cause like that one. A Mardi Gras bead. You're getting ready to pull out a bunch of those things. Those all create conductive hearing loss. What about Play-Doh? Oh, Play-Doh creates an instant conductive hearing loss. The one that you really can't do a whole lot about is a sensory neural hearing loss. The most common example is presbycusis. It is a loss of high-pitched tones that are typical in our older adults who present with hearing loss. Now listen, if we had a 4-year-old in front of us who had presbycusis and couldn't hear, I don't think there's a single person in this room who wouldn't do everything they could to get a hearing aid for that 4-year-old. But when the patient is 74 or 84, we kind of just let it go. I want you to think about how wise that might not be when you know this fact. We know that in elderly adults who begin to lose their ability to hear, look at what results. They get diminished nonverbal executive function. Do you know what that means? You lose the ability to do things that manage your life, like manage your calendar, manage your affairs, manage your ability. So it is just as important for you to try to get hearing help for an older adult as it is for a 4-year-old. Because the last person you want to lose non-executive verbal function is one of these people. You will end up in assisted living or complete living somewhere very quickly. So please be aggressive with your older adults. We treat presbycusis aggressively. So listen, what are some clues? The early clues before people start saying, huh, what? What did he say? Huh? The early symptoms are crickets. I have a patient who tells, Amelie, I hear crickets. I hear crickets. This man worked around giant jet engines for 25 years. He's got hearing loss. I can't believe he hadn't had it before now. Ringing in the ears is a symptom that precedes, huh? What? I didn't hear. What did he say? So all of these are very early symptoms, bells, crickets, and ringing, all right? That precedes the inability to be able to hear and distinguish speech. We're almost there. Hang with me. Let's talk about some eye things and then we'll wrap it up. If someone comes in and says, I think something went in my eye, you have to evaluate that patient just as though there is something that is in their eye. And so your workup for an ocular foreign body has got to be like this. There are 4 steps. The first one always is to start by assessing visual acuity. Listen, there's something you must do. You must evaluate vision in the right eye, the left eye, both eyes, and make sure you document it. You never want somebody to say, today my vision is 20/80, but I'm telling you, before I went to see that nurse practitioner 2 days ago, I could see everything on the chart. So make sure you document visual acuity. You always start eye assessments with that. The second thing you always do is you look at the eye under magnification and see if you see something in it. Well, if you are lucky enough to have a $25,000 slit lamp, well, good for you. You should never miss one. Some people will be lucky enough to have a $2,500 pair of binocular loops. Well, if you're lucky enough to have that, good for you. You shouldn't miss one either. Most of us are going to have this 25-cent pen light. So you're going to pull the light off the wall and look at the eye and see if you see something in it. But listen, if you want to examine the eye and see if something is impaled in the eye, the best way to do it is not by looking at the eye straight on. The best way to do it is to look at the eye from the side. You want to be able to look at the globe of the eye. So what you need to do is look at the patient head on, then make your way this way and do a 180 of that patient's eye to see if you see something in it. If something is impaled in the eye, you'll have a much better chance of seeing it not head on, but from the side where it will be protruding from the globe. You got it? So make a 180 in lieu of one of these more expensive tools. And you'll pick up more foreign bodies that are impaled in an eye than if you just look straight on. So that's the second thing you're going to do. The third thing you're going to do, always when you expect or suspect corneal abrasion, is fluorescein staining, either with a stick or a drop. If there's a break in the integrity of the cornea, as you see right here, then what you'll get is fluorescein staining, all right? And that lets you know what you've got. I used to always stop right here when somebody said something was in my eye. I had a real big problem with flipping the eyelid. Anybody else have my problem? I'm over my problem now. Let me tell you why. It really is pretty easy, and when you do it and you flip the lid and a piece of hay or grass pops out and the patient gets instant relief, you'll do it again, all right? And that's what got me over my fear of it. So listen, the last part when you suspect that something can be in the eye is to evert the lid. And you use a cotton swab, and to be honest with you, after you do the first one, it's like the next one is so easy. So practice and do it. You're not going to hurt them. But again, if something is right into the eyelid when you can't see it and you do that, it comes right out. Instant relief. It makes you feel good. The patient feels even better. What about red eyes? Well, there are some things that signal big trouble when a patient presents with a red eye. And here's what we think of. The only one of these red eyes that I think you ought to keep is somebody who's got a foreign body sensation. Maybe it's scratchy, gritty. Maybe it's a corneal abrasion. Maybe it's conjunctivitis. But when you have a patient with a red eye and a change in vision, they're not your patient anymore. They need to see ophthalmology. If you've got a patient with a red eye who cannot keep his eye open, they're not your patient anymore. They need to go to ophthalmology. And that is always the case with a red eye in a patient who is photophobic. What does that mean? Sensitive to light. That is never your patient. So send those people over to ophthalmology. A couple of terms with the eye that I think you need to know about. This is a chalazion, right? It's hard, it's non-tender. It's caused by an inflammation of the meibomian gland. Typically we get those referred to ophthalmology. Ophthalmology will laser that out. Takes about 10 minutes. Costs about $1,800. And then the chalazion is gone. Sometimes that's in contrast to a stye. A stye starts out tender, and styes go away. A meibomian gland inflammation like a chalazion almost never does. You almost can't wait that thing out. So be alert to those two eyelid things. A cataract is something you should be alert to as well. A cataract represents an opacity in the lens of the eye. And if you have a cataract either unilaterally or bilaterally, you can't see very well at all. I want you to note, though, where your lens is. It's not here where we put a contact lens. It's here in the eye. So this is a part of the eye that fogs up, where the patient who's got a cataract very slowly and gradually loses their ability to see and recognize colors. Whew. Get them referred. I'm waiting for a cataract drop. I get a cataract, just put a little drop in your eye and the cataract goes away. What do y'all think? That will never be discovered. It will also never be discovered to have a catalyst to create a diamond. What do y'all think? No. Take a big deep breath. Let's check your knowledge. Which symptoms indicate a high likelihood of group A strep? Okay, not number 1 because it is not rhinorrhea. Number 2, it is not nasal congestion. The 3 things that indicate strep or high likelihood are tonsillar exudates, fever, and an absence of cough. You got it? So number 4 is incorrect because cough is in there and it shouldn't be. So number 3 is your best answer. Look at your next one. A 30-year-old patient has been using oxymetazoline spray, aka Afrin, for nasal congestion for the past 9 to 12 months. Oh, you don't know how common that is. She states that she can't breathe if she doesn't spray 3 or 4 times a day in each nostril. What do we call that besides trouble? What do we call it? Rhinitis medicamentosa. Rhinitis medicamentosa is that rebound stuffiness that people get when they can't get their shot of Afrin or duration or whatever they get. How do you fix that, by the way? You get them to spray only one nostril at a time. So when you can't breathe, spray the left nostril. Next time you can't breathe, spray the right nostril. And at the same time, you start them on a topical nasal steroid. But once you've had Afrin or duration and you've had it for many days in a row, you never want to give that stuff up. So you got to work with patients very slow. I had a patient who used to wake up in the middle of the night 3 and 4 times to spray. I wish I could tell you the whole story. But anyway, number 2, rhinitis medicamentosa. Look at this patient. A 24-year-old female complains of intermittent, irritated, dry, red eyes. This is her eye. I'd like to know what you think it is. So here's what I note. She's got red eyes. You see how prominent the vasculature is? She's got eyelid margin erythema. You see it? And she's got crusting on the lashes. What is that? Blepharitis, exactly. Look at this patient. A patient complains of a red eye and moderate ocular discharge. There's no change in vision, no history of trauma, no photophobia. First of all, I'd like to know what you think that describes. What problem? Anybody thinking conjunctivitis? You should be. Moderate ocular discharge, red eye, and no red flags. What's a likely historical finding? Morning eyelash crusting, exactly. So number 1. Hey, we're there.